Rain spoke about that in his first talk, or alluded to that, and now he'll speak about that in details. What is this fluid accumulation syndrome, Manu?
Thank you, Xavier. So we have a little change in the program. First, fluid accumulation syndrome. Then I will talk about bioelectrical impedance analysis, what it is, how it works. And then Xavier will tell us everything how to avoid a positive cumulative fluid balance. We will have a break at 12 noon for the Friday prayer. And then we just wait for you to come back, and then we continue. Okay, so what is fluid accumulation syndrome? I'm still an internist, and my disclosures have not changed between the previous lecture. So for that, we need the framework, 10D, definitions. What are we talking about? Fluid withholding is the decision not to start fluids, like the decision not to give maintenance when not needed, for instance. Fluid retention, when our body is accumulating fluids. Fluid creep is the unintentional administration of fluids. We only have the intention to give antibiotics, but we can only give them diluted in other fluids. Fluid tolerance, I told you, maximum amount of fluids that can be given without causing harm. Then we have fluid restriction. So we limit the daily amount of fluids because there is fluid retention. And fluid retention is the body that accumulates fluid, like in capillary leak. Conservative or restrictive fluid management is to avoid a positive cumulative fluid balance. Xavier will talk about that. And a liberal or standard, it's the opposite. But usually there is different definitions. If you look at the studies, sometimes restrictive is standard and liberal is a bit conservative. So we need proper definitions. Fluid withdrawing is either reducing the fluids or completely stopping them. So there is a bag and you decide, I move the bag, I remove the bag, and I stop it. De-escalation is the whole concept of limiting fluid intake, limiting positive fluid balance. It can either be done by fluid withdrawing or by fluid withholding or restriction. So you want to administer less fluids on a daily basis, whereas de-resuscitation is the active intention of removing excess fluids with diuretics or mechanical devices. So those were the definitions, and I told you already that FAS is a syndrome. It's not a disease. It can occur within many disease states or conditions. Yet, many surgeons, anesthetists, intensivists, don't pay proper attention to FAS. And let me illustrate this with a typical case of perforated viscous abdominal sepsis. Postoperative day 0, blood pressure is low, let's give a bag of saline. Urine output is low, let's give another bag. CVP is low, let's give another bag. Maybe the patient is fluid responsive. So at the end of the day, the patient may have received 5 liters of saline. Why? Because it's kind of a reflex. Whenever something goes wrong, we believe that fluids should be good. So on postoperative day 2, you can see the abdomen is distended, creatinine milligram per deciliter increased, and on day 4, there is a positive cumulative fluid balance, and urine output drops with a further deterioration of creatinine, and CVVH is started. Fluid accumulation syndrome. On day 7, there is a cardiac arrest in the ICU, and it's a real case about 25 years ago when I started working in Antwerp. Condition was acute mesenteric ischemia due to secondary abdominal hypertension due to fluid accumulation syndrome. So it's real, it's there, but we need to pay more attention. Intra-abdominal hypertension is a killer. But the question is, did you do everything, like in this patient, to prevent fluid accumulation syndrome? And as previously stated, are we shifting our mindset and start thinking fluid stewardship like antibiotic stewardship? So, 1 patient in 5, 1 in 5 will suffer from deleterious effects of inappropriate fluid management. As I told you, can be too little or too much. We know there are only 4 indications to give fluids, but the largest one is the fluid creep, the unintended one, and that accounts up for 33%. So again, we are humans and we make mistakes. I told you about the 10D framework, and now the focus is on de-escalation of fluids after saving the patient, and more specifically, de-resuscitation. So fluid overload will always lead to hypervolemia, hyperhydration, and peripheral edema. And hypervolemia, because of hydrostatic forces, will always lead to edema, but the opposite is not true. It's not because you're edematous that you're also intravascularly overfilled. So that's why maybe we need more and better definitions when it comes to fluid overload, because some colleagues think fluid overload is hypervolemia, but it's not. Like Jean-Louis Vincent, Michael Pinsky suggested, maybe avoid fluid overload. And everything you need to know about de-resuscitation can be found in this open access paper written with Greg and Marlies in intensive care medicine. So you can just download it. And just out now is a scoping review on fluid accumulation syndrome, with all the definitions and everything that will be told here. So what is the definition for fluid accumulation? It's an increase in body weight in relation to baseline body weight. Problem is, usually we don't know, but it's any body weight that we have from the patient. So you can actually have a daily measurement of body weight, and then you see what is the excess body weight. Like my own case, I gained 8 kilos of body weight, water, not anything else. Or relative with respect to the cumulative fluid balance calculated by the nurses, but it's very difficult to have an accurate daily fluid balance. Maybe peripheral edema can be quantified. Maybe we can calculate circulating blood volume with isotope dilution techniques. Maybe look at volume excess. We will learn about bioelectrical impedance analysis, how this could be helpful to calculate cumulative fluid balance and assess fluid accumulation. We know most of the water is intracellular, 1/3 extracellular, 1/4 intravascular. When we talk about fluid accumulation, we talk about an increase in the extracellular water, whereas when we talk about hypervolemia, it's an increase in the circulating blood volume. So these are 2 distinct different terms, and that's why we propose fluid accumulation and fluid accumulation syndrome, which is any degree of fluid accumulation as a percentage with a negative impact on end organ function. Like I told you, the PF ratio, the lung water, abdominal pressure, that can be associated with global increased permeability syndrome, the Michelin man, the capillary leak, and so forth. So this is the new definition. So remember, we are giving fluids to improve the microcirculation, to increase stroke volume. By definition, fluid responsiveness is defined by a 15% increase of stroke volume. But of course, this oxygen-rich blood should reach the tissues, the microcirculation, and improve tissue and organ perfusion. So both are important. This is a healthy capillary. This is the same capillary only 5 minutes after an insult. So capillary leak can occur very fast, and it's like a leaky bucket. This is a healthy capillary in a hamster cheek pouch. So you look at it here. Now we're doing an insult into the peritoneum of this hamster. And after 10 minutes and 30 minutes after the insult in the peritoneum, the cheek becomes leaky. So capillary leak does not only occur fast, it also occurs at a distance. What is this? Well, this is seagrass at low tide. And this is the same seagrass at high tide. It's beautiful, it's nice. Why did I show this? Because it resembles the glycocalyx. The glycocalyx comes from glyco, sweet, and a husk or a shell surrounding all the vascular endothelium As you can see here, it is like the seagrass. And it forms a layer between the vascular lumen and the endothelial and subendothelial space to prevent free movement of water, proteins, colloids like albumin, and so forth. But after an insult, we see that this glycocalyx may be damaged, like with sepsis. And also fluids can damage the glycocalyx. For instance, saline, if you give it in a bolus, it'll ruin the glycocalyx and lead to hyperpermeability. We learned that sepsis is time critical. So the only reason is when all these conditions are present. And the fifth one to check, is my patient at risk for fluid accumulation syndrome? Fluid accumulation we can do, and healthy volunteers will evacuate the excess fluids. So what does the literature tell us? That accumulative fluid balance is an independent risk factor for outcomes. And here you can see that survivors in green have a cumulative fluid balance going to 0 by day 4. And you can see if the patient is on diuretics or spontaneously, you can see always that non-survivors have a more positive daily and cumulative fluid balance. We can de-resuscitate, and this is just a dramatic case showing 33 liters of net negative fluid balance. You can question yourself, why did they wait until the positive fluid balance was 33 liters positive? But with aggressive ultrafiltration, it's possible. But we have to remember that it's not because you're fluid unresponsive that you have fluid accumulation or that we need to diurise. So you don't need to treat every patient with fluid accumulation or fluid unresponsiveness. So it's, again, the same. When you're fluid responsive doesn't mean that you need fluids, and the opposite, when you're fluid unresponsive doesn't mean that you need to be fluid removed. Brings me to the Rose model. After the initial hit, whether it's sepsis, burns, pancreatitis, trauma, patient is hypovolemic, and fluids are life-saving. Fluid balance should be positive. Then we have the second hit, which is ischemia reperfusion. Fluid accumulation becomes a biomarker for disease severity, and here we need to maintain homeostasis, support the organs, neutral fluid balance, and we move on to the stabilization phase after days, where we can start nutrition. The third hit is this Michelin Man, global increased permeability syndrome. And here, some patients may need a little help to remove fluids. And we will try to give you some hints and tips to guide you through the different phases. Of course, when we are removing fluids, we must avoid, again, hypoperfusion if the patient is getting hypovolemic. So hence you have the ROSE acronym, and it's like giving water and the blossoming of the rose. Remember, the last one is a dry one. It's picked up, and as you can see, we just wrote a narrative review in severe acute pancreatitis, where you can also identify the different phases as to the ROSE model and also avoid fluid accumulation, because severe acute pancreatitis with third space fluid accumulation, intestinal edema, abdominal hypertension, they are very prone to that. So within these different phases, we have these four distinct hits. We talk about the ebb phase when the patient is hypovolemic, and the flow phase is when the patient gets better and starts diuresis again, but sometimes it does not happen spontaneously. So, saving lives, patient rescue, resuscitation. Of course, only when needed. Patient should be fluid responsive, fluid tolerant, tissue hyperfusion, as we explained previously. Optimization is focused on organ rescue. So we must save the kidneys, we must save the lungs and the liver. Avoid fluid creep. And we stop the fluids when the patient becomes fluid unresponsive. Stabilizing is organ support, homeostasis. Here we can think of enteral nutrition, maybe hypercaloric feed to lower the fluid intake. And the evacuation phase, I told you most of the patients evacuate spontaneously. Some need a little bit help with late goal-directed fluid removal, and we will discuss later on in the case. So here are the 4 phases. And if it comes to fluid management, resuscitation, isotonic balanced, except traumatic brain injury, upper GI losses, saline. When it comes to optimization, stabilization, here we must avoid maintenance. Why? Because the patient receives fluid creep, enough fluids to cover the daily needs. So during all the phases, we should avoid excess sodium, excess chloride, and think about giving medication orally. Or instead of in a little bag, give them in a bolus injection. So we need to discuss with the pharmacist and a medical pharmaceutical committee whether this is feasible. But if the gut is working, many of the drugs like paracetamol, like valproate, can be given orally instead of intravenously. Think about enteral nutrition and hypercaloric to limit the fluid intake. Remember, all fluids are redistributed and may lead to fluid accumulation. And fluid accumulation is a biomarker. So think about source control. Do the CT, do the ultrasound, check for an abscess, a collection, change the antibiotics, ask for the surgeon. During resuscitation, maybe there is a place, although it's not supported by hard evidence, for albumin to evacuate. So, after rescuing the patient, with goal-directed therapy, we optimize organ function, late conservative fluid management, we stabilize the patient, late goal-directed fluid removal to evacuate the excess fluids and thereby saving the patient. Fantastic, isn't it? Well, at least that's the theory. So how we do that? Goal-directed therapy may be based on macro-hemodynamics, like fluid responsiveness, PPV, passive leg raise, volumetric preload, like with the PICO. We will discuss that later. And when these normalize, when lactate normalizes, no longer fluid responsive, PPV normal, then we can stop. We evacuate when there is an impact of fluid accumulation on organ function. Easy ones, PF ratio, lung water, POCUS, VEXUS score, low PPV, abdominal pressure increased, so this is your guidance. And of course, during evacuation, we must look at perfusion, ICG-PDR, or mixed venous oxygen saturation, or central venous one. Problem? There is, as of today, no one single study taking the patient through all these phases. But to give you some guidance, in this paper, we give some tips, tricks, targets, triggers, and we take a little bit more deeper into the ROSE concept. For resuscitation, triggers to start fluids, shock. Of course, if the patient is not in shock, no need. Triggers to stop fluids when there is unresponsiveness or when shock has resolved. Triggers to start fluid removal if there is a fluid accumulation syndrome, if there is a global increased permeability syndrome, if there is anasarca, Michelin-Man, it's not cosmetic, there is a problem. And triggers to stop fluid removal, again, if there is fluid responsiveness, passive leg raising becomes positive again, or hypoperfusion. Remember, fluid responsiveness is the normal situation. You are all fluid responsive as we speak. So it's all about setting the right targets, triggers, safety limits to avoid complication, global increased permeability syndrome. So the pathophysiology of fluid accumulation syndrome, so the definition, remember, any percentage of fluid accumulation with new onset organ failure, and organ failure, of course, caused by the edema, so lung water, abdominal hypertension. The pathophysiology, as stated, it's peripheral vasodilation, myocardial depression, metabolic increase due to VO2 imbalance, the capillary leak, endothelial glycocalyx layer degradation, and then you have the venous hypertension and the organ congestion. Remember the waterfall. This has an impact on all organ functions. And the anasarca that we see at the outside is just a mirror of what is happening at the inside at each organ level. So when we are resuscitating fluids, there will be second, third phase fluid accumulation. There will be bowel edema, abdominal distension, increased abdominal pressure, compression of the vena cava, venous return is reduced, reduction in cardiac output, and then we have forward failure and reduction of blood flow to the organs, and you have a vicious cycle of multi-system organ failure and dysfunction. And we must stop it by getting a 0 to negative fluid balance. Why? Because fluid accumulation at the outside mirrors fluid accumulation at the inside, and it will result in venous hypertension, the Michelin Man. So the diagnosis can be done clinically, looking at fluid balance, body weight, BIA measurements. Ultrasound may have a place, and advanced hemodynamic monitoring. Clinical signs, usually aspecific, but I advocate daily fluid balance, cumulative fluid balance, daily body weight, and the change of body weight to baseline. Capillary refill time, interesting. Biochemical, look at hemodilution. Fluid accumulation will lead to a drop in albumin, a drop in protein, and a drop in hematocrit. Look at the capillary leak indicator, CRP divided by albumin, and urine albumin over creatinine ratio. Very interesting in burns. During the first hours, you see a huge leak evidenced by urine albumin creatinine ratio. Imaging, rather aspecific, is a plain chest X-ray, but ultrasound is interesting, as well as the hemodynamics. Filling pressures can be increased if you have PEEP, auto-PEEP, abdominal hypertension. So I think volumetric preload with a global endostolic volume is much better. The absence of fluid responsiveness and a negative passive leg raising tell you about the safety to remove fluids. And I think Xavier will tell us more about that. Look at the impact on organ function with lung water, PF ratio, abdominal pressure, abdominal perfusion pressure, maybe other biomarkers in the future. And then more specifically, the bioelectrical impedance analysis with the extra intracellular water, but also the extra intravascular fluids, as we will show later on. Here are just some examples. Negative cumulative fluid balance. So the more negative the balance, the more likely that you're getting liberated from the ventilator. What about circulating blood volume? You can see that there doesn't seem a relation between low circulating blood volume and fluid responsiveness, because regardless of the volemia status, you can be fluid responsive or fluid unresponsive, and vice versa. You can be fluid responsive with hypervolemia, euvolemia, normal volemia. It just depends how you set the ventilator. And then I told you about quantifying peripheral edema, the goddess sign. In this study, they tried to identify interstitial edema at the level of the abdominal wall to match this to fluid accumulation severity. So maybe in the future. Advanced hemodynamics, we will get back to this later, like transpulmonary thermodilution, where you have the extravascular lung water. You can do a calibration, so you have to inject a cold bolus, and you have to look at the thermodilution curve, because here you see a kind of a double hump, and this is referred to as the camel curve. And what is the camel curve? It is an opening of the foramen ovale due to right ventricular hypertension because of ARDS. Could be pulmonary hypoxic vasoconstriction. So this is a kind of a sign that the patient is in a bad shape, and this may be related to secondary ARDS fluid accumulation syndrome with an increase in the lung water and the pulmonary vascular permeability index in the lungs. These advanced calibrated hemodynamic monitors give us information on preload, afterload, contractility, dynamic functional hemodynamics, the PPV, as well as organ function, like the lung water. And this is important to assess the negative impact of fluid accumulation. So prevention is minimizing the fluid intake, and we call this restriction. This could also be withholding, not starting fluids, not starting maintenance, not starting resuscitation because there is no lactate, there is no shock. Always we should limit the sodium and chloride content. When it comes to treatment, you can withdraw, lower the volume, lower the rate, and this is referred to as the de-escalation. And then you can use diuretics, combination, or renal replacement therapy. So de-resuscitation is active fluid removal. It's not passive, it's not lowering the speed, it's on top of that, giving diuretics, giving hypertonic albumin with diuretics, doing CVVH. So it's an active intervention. It's a treatment as well. So it can be too fast, too little, too slow, too late, too aggressive. So it's like a drug. And you should also think twice before starting. There is no one size fits all, so we should go for patient-tailored, individualized, personalized treatment. So basically, the management comes on prevention with fluid restriction, the care, supportive measures, and the cure, which is the de-escalation, the de-resuscitation. Prevention, care, and cure. And just briefly, the key parameters for prevention is fluid restriction, so not deciding to resuscitate because there is no lactate or the patient is not a fluid responser. Remember, should be shock, there should be tissue perfusion, there should be fluid responsiveness, fluid tolerance, and no risk of fluid accumulation. Fluid withholding is the decision not to start maintenance, for instance. And minimize creep fluids. These are the little bags that we use to dilute our drugs. Don't give saline. Dilute them in glucose or dextrose. Limit sodium intake. Limit chloride intake. Think about small volume resuscitation. We don't have the evidence, but I think there is a place for albumin, especially albumin 20%, in severe septic shock capillary leak. There were in the past studies with hypertonic solutions, hypertonic lactated saline, 3%, in a bolus of 4 ml per kg, but I'm concerned because it's a lot of salt. So I would not advocate those, despite their initial effect, beneficial effect. So the care is about the monitoring. So you should have baseline hemodynamic monitoring. I think an A-line, I think a CVP. Basic ultrasound, transthoracic ultrasound measurement. We should have fluid balance. We should have body weight. We should have BIA measurements. Maybe advanced hemodynamic monitoring. Think about early vasopresses. Remember the video. You squeeze fluids from the unstressed to the stressed volume. It's autotransfusion. Giving early presses limits the total amount of fluids that you need to give to achieve the same effect on stroke volume. One of my favorites, lower the intra-abdominal pressure. Improve the compliance of the abdominal wall by sedation, analgesia, maybe sometimes neuromuscular blockers. Evacuate intraluminal contents, nasogastric tube, rectal probe. Evacuate free abdominal fluids, ascites, do an ultrasound, drain it, paracentesis, improve gastric motility, optimize abdominal perfusion pressure, MAP minus the intra-abdominal pressure. And maybe some vasodilators or inodilators could be helpful depending on the condition. And then the cure is the de-escalation of fluids. Really, you decide, I stop this fluid, I remove it because it's no longer needed. And then we have the de-resuscitation with the medical part, diuretics, usually loop diuretics, furosemide, or you can have a combination with acetazolamide, indapamide, spironolactone, depending on the condition. For instance, if sodium is high, you can give indapamide. If there is some alkalosis, you can give acetazolamide. And you have a synergistic effect. So sometimes you give 4 diuretics. You can give the diuretics in combination with albumin, 20%. Greg Martin showed that it improves PF ratio. And we use it as POL treatment. I will show you later. And then mechanically is the CVVH. Also compression stockings if you have large peripheral edema. And by doing all this, we hope to improve morbidity and mortality. So think about withholding. The best fluid is the one that has not been given unnecessary. Of course, if they are needed, give them. They are drugs. Just because your lactate is increased doesn't mean you're hypovolemic, okay? Because lactate can be increased by increased production or by decreased metabolization. For instance, if you have liver failure or shock, you can have an increase in lactate. If you're giving Ringer's lactate, like in burn patient, you will see an increase in lactate, which does not mean that there is tissue hypoperfusion or hypovolemic, or that this patient is in shock or needs fluids, because only when lactate production is related to tissue hypoxia, we need to give fluids, and fluids may be helpful, but not in the other conditions. In this study in CABG patients, we looked at the first 2 days, what are the fluids given, and you can see 6 liters in and 5 liters out. So we gave, and this was before we implemented fluid stewardship, and what's the problem? Because these patients, standard, got maintenance solutions. It was glucion, which is a hypotonic balance, but still, it was fluids that probably were not needed. And also, there is about 1 liter over the 2 days of creep fluids, dilution of paracetamol, antibiotics, and so forth. And Niels van Regenmortel showed that in yellow, the creep fluids during the stay of the ICU increase from the 33% to even more because of the drug dilution. That's important. And hypertonic solutions are best because they result, as I showed you, a lower sodium balance, a lower fluid balance, because a higher cumulative solute-free water clearance. So hypotonic for maintenance, hypotonic for drug dilution. So this was the CABG study, and you see paracetamol, because it's in 100 cc if you give it. So it's almost half a liter, and then antibiotics and other medications. So you end up in CABG with 1 liter of creep, unintended, so you don't need the maintenance. So the albumin, if you look at the SAVE and the Albios, there is a preference in severe septic shock in favor of albumin. This was, I think, albumin 4%, and this is albumin 20%. And albumin results in an improvement of fluid balance. So I think it makes sense to give at least after the 30 ml of kg in the surviving sepsis, and it's also recommended by the sepsis guidelines to think about colloids, and then the only one left is albumin. As you can see in the other studies with albumin, there is an improvement in the cumulative fluid balance as compared to crystalloids. Despite that, albumin has a lot of other beneficial effects. It's anti-inflammatory, it has coagulation properties, anti-infectious properties, so it may be a good solution despite the clear-cut indications, as I told you, after paracentesis and spontaneous bacterial peritonitis. So maybe more on that when we have the results of the Albios 2 trial. Oh, it's not moving. Is it blocked, my presentation, or can you go to the next slide? Or maybe the battery, Xavier, is empty, is possible? I don't know. But we're almost there. What the next slide is albumin. Okay. Oh yeah, the early norepinephrine. So there is an effect, so you need to give less fluids to get the same effect, so that makes sense. The abdominal pressure, we talked about that. An interesting one is optimization, so a kidney care bundle. We want to preserve the organs, and this is a paper we recently published where we have a stepwise approach and also incorporate abdominal perfusion pressure, because increased abdominal pressure is key to understand worsening renal function in patients with advanced cardiac failure. Think about the difference between de-escalation and de-resuscitation. So stop or limit the fluids, and then de-resuscitation if the patient has an impact on end organ function. It's a difficult journey, and the only thing I would like to mention is the furosemide stress test. It's known by nephrologists. You give 1 milligram per furosemide for a patient naive to furosemide, or 1.5 milligrams per kg as a bolus. You wait 2 hours. If urine output is 200 or more, the patient passes the test, and there is no risk for renal replacement or AKI. So you could do this to see if the patient is ready for de-resuscitation, the furosemide stress test. And you can do this in combination, as I told you, of diuretics, depending on the underlying condition. One word about the PAL treatment, PAL, PEEP, albumin, Lasix, furosemide. So when you have a high lung water, a capillary leak in the lungs, you increase the PEEP equal to the abdominal pressure. So in abdominal hypertension, the diaphragm is up. You recruit the lungs, you put the PEEP equal, so you have recruited. You squeeze the fluids out of the alveolus into the interstitium. Then you put the hyperoncotic albumin. By doing so, you increase the colloid oncotic pressure and you attract fluids from the interstitium, and then you give the furosemide and you can clear the fluids out of the alveoli and out of the patient. Every step you wait 30 minutes because you need the equilibration between the different body fluid compartments. And this has been shown by studies by Robert Hahn that in fact giving hypertonic albumin is able to recruit fluids from the interstitium. So we did this in a pilot study of 114 patients, and the patients in the PAL group received higher PEEP equal to abdominal pressure. They received albumin to normalize serum albumin to 30 grams per liter, as you can see there. And this resulted after 1 week of de-resuscitation in an improvement in PF ratio, a lowering of the abdominal pressure and the lung water by keeping the cumulative fluid balance in balance. So it works, but it takes time for these fluids to get shifted. And the patients receiving the PAL had better survival and faster weaning. So it makes sense, but as said, as a pilot study, in a meta-analysis, you can see that de-resuscitation can lower abdominal pressure, and the more fluids you de-resuscitate, the bigger the drop in abdominal pressure. And I think it's 12 o'clock, and this was just, okay. So we're gonna stop for the Friday prayer now. This is the magic formula we will tell you all about later. So see you back, I don't know, in how many minutes? How much? 20 minutes? Back in 20 minutes. Okay, thank you.